So I would like to introduce the first speaker, Dr. Richard Bucholz, who's the director of the Division of Neurosurgery at St. Louis University Medical Center, who will show you and tell you about his experiences with a investigational product that we developed together with Medtronic Navigation and some other multimodality imaging studies. Dr. Bucholz.
Thank you very much, Joe. It's a great pleasure talking to you tonight about our experience with the Dextroscope. First, I'd like to acknowledge my co-author, Lee McDermott, who has been absolutely instrumental in implementing many of the imaging, many of the developments that you see here tonight. Clearly, we as neurosurgeons are dealing with an information overload. We are dealing with imaging now that allows us to go into multiple modalities in terms of rendering care for our patients. We have a combination of structural imaging as depicted by CT and MRI, as Joe has very elegantly shown you, diffusion tensor imaging. The other interesting aspect of imaging that's now available to us is functional imaging, looking at the actual location of function in our specific patients, as depicted by functional MRI and magnetoencephalography. And added on to that, we're having the ability to do chemical imaging, so that now we can, with mass MRI spectroscopy, look at the chemical constituents of specific aspects of our patient's brain. All of this information is extremely important to us as surgeons as we move ahead and do our surgical planning, but it would be my very strong contention that the two-dimensional world, as Joe has indicated, is not the way to do this planning in the best possible way. Now, the magic of image fusion, the ability to relate all of these imaging modalities to one common image, is the thing that really, I think, generates the interest and is really the power behind the Dextroscope. Really, if you think about it, for example, magnetoencephalography, for us as neurosurgeons, makes sense only if we relate it to structural imaging. Some of us can look at raw MEG traces, but the fact of the matter is the vast majority of us as neurosurgeons really want to be able to use magnetic source imaging in order to determine localization of function as opposed to the raw data. PET, for example, is another imaging modality which is very eloquent, but at the same time is somewhat of a Rorschach test trying to interpret a PET study unless you do it within the context of image fusion to another structural imaging with higher resolution. So fused images, to me, are the way to go in terms of really interpreting the multiple sources of information that we're presented with as neurosurgeons. Now, many of us in the past have been benefactors of this sort of fused image. This is a patient with a low-grade glioma involving her temporal lobe. In this case, we have MEG data depicted by little round spheres indicating the motor and sensory cortex. The actual abnormalities, in this case, demonstrated by FLAIR abnormality in light green, and the cortex is indicated on a T1-weighted sequence. This type of fused image, although great and compelling for presentations at, for example, the AANS, is something that heretofore was very difficult for us to achieve on a routine basis as neurosurgeons within our hospital facility. We could do this if we're going to present it to a major group of neurosurgeons, but we couldn't really take advantage of this fused imaging capability as a surgeon unless we had a dedicated department of imaging group. The Dextroscope really changes that. The Dextroscope, in effect, places the capabilities of an imaging department in your hand. It fully supports the ability to do image fusion across multiple modalities, including MR spectroscopy, three-dimensional angiography, et cetera, as you'll see tonight with the multiple demonstrations that I'll go to here tonight. Variable transparency and the ability to ramp up and down the different co-fused items really allows the surgeon to get a very detailed appreciation of exactly the anatomy, both functional and structural, of their patient. And the final rendering within a stereoscopic image data set really is the icing on the cake. It really does bring home to you as the operating surgeon what is going on with your patient in order to make the best possible plan for your surgical intervention. Now, to illustrate this, I'll start off the discussion with one particular case that we were dealing with. This is a 25-year-old male who presented with post-ictal weakness. It was transient in nature and completely resolved. The neurological examination at the time of presentation was absolutely normal. The initial presentation was in 2003. There was no evidence of any abnormality elsewhere. Here's the flare sequence on this side, and here's the T1 contrast. We see all the markers, so to speak, of a low-grade oligodendroglioma, absence of contrast enhancement, and a bright abnormality seen on flare-weighted sequence. This patient underwent a resection of this lesion using intraoperative magnetic resonance imaging in a flare-based sequence. This is the immediate post-operative MRI. There is some increase in signal abnormality on flare as normally seen following a surgical intervention. There would appear to be a good resection on T1 rated imaging. The patient was followed with serial MRI scans. This is 1 year post-op, and this is 2 years post-op. The scans are acceptable. There seems to be a good resection. I would, however, draw your attention to this very small area of flare-based abnormality, which appeared between this year and this year, 2 years post-op. Now, at 3 years post-op, we have this image. This is somewhat more concerning. That small area of flare-based abnormality has now become somewhat larger. There is still no essentially contrast enhancement whatsoever on T1 sequencing. However, this abnormality was enough to make us very concerned as to what the true etiology was of going on in this particular instance. MR spectroscopy was performed, looking at creatinine-choline ratio. The diagnosis was made of a recurrent malignant glioma. This, again, in the patient with a grade 2 oligo demonstrated 3 years previously. The patient had recovered fully from his transient hemiparesis. We did not want to inflict any weakness upon him by repeat operation. And so what we did was perform a MEG using motor and sensory evoked modalities to define the location of the sensory and motor cortex. Now, we did do a co-registration with the Dextroscope, and I'll show you that next. This is the co-registration, and just to give you some idea of what you're looking at, this is obviously the superior sagittal sinus. This was gotten off of the T1 weighted with contrast. So, and then we have superimposed upon this MEG-related data. Here we have the motor cortex indicated by a small square. We have the index, the sensory index area. We have the multiple fingers as depicted by MEG on this side. And now what you can do is in real time rotate the three-dimensional data set and actually depict very well the components in this particular image. I would point out here this light turquoise color is actually the area of greatest MR spectroscopic abnormality. This is actually being visualized through the encephalomalacia present after the initial operation. So in this one image, you not only see the structural anatomy of the brain in terms of the T1 image demonstrating a possible avenue approach for this lesion, you're seeing the sensory and motor information on the same data set, and you're also seeing the chemical abnormality within the data set. This then allows you in real time to rotate this image back and forth, and you can go ahead and crop and edit this as you need to, as indicated by this video. And you can actually now go through the data set, crop it, rotate it, and really get a very good appreciation of exactly the area of abnormalities. Now, one thing that you might see right off the bat is that there are two areas of spectroscopic abnormality contralateral to the initial tumor presence, and this is true. There was actually evidence of chemical abnormality on the opposite side. Certainly, we did not want to intervene on that opposite side for fear of weakness developing on the opposite side of the body. But for me, this type of pattern of detection and the ability to crop and rotate really gives the best possible surgical picture in terms of determining how to go in on this particular case. Now, with that, what we will do, stop this. Now, if we'll go ahead, let's switch over to the 3-beam display, if we could. And if you'd put on your glasses here at this point, this is the data set that we're talking about. Now you can see right here these small squares. These are the depiction of the areas of sensory localization for the MEG data. And you can see very well exactly where those areas are located. At the same time, using the angiographic data, which is, again, the T1 with contrast, you can see that right in the area of the prior surgical resection is the vein of Trollard, a rather large vein of Trollard indeed. And then here, deep down, we can show the MR spec data. Here is the area of maximal spectroscopic abnormality. And so what we were able to do is plan a surgical course which went in and biopsied this area, came through the area of surgical defect, and avoided both the sensory cortex as well as the vein of Trollard. And we were all able then to do this preoperatively in a very seamless way without any other type of manipulation or input, either from radiology or from other sources. So again, if we can switch back over again, that'd be great. So in this situation, to me, the benefits of the Dextroscope planning were threefold, basically. We were able to define the target by using MR spectroscopic abnormality. We were able to define our surgical path by avoiding eloquent cortex as depicted by MEG. And we were able to decide on our entry point by avoiding key vascular structures, in this case, the vein of Trollard. This was all capable of being done with the image fusion capabilities that are currently inculcated within the Dextroscope. One of the things that became immediately apparent was, well, if we can do a very good job at surgical planning with the Dextroscope, why not be able to bring that into our navigational system in the operating room? It became very obvious to me that these very exquisite, very detailed plans that we were developing with the Dextroscope should be perfectly transportable to the stealth station, which clearly we had a lot of experience with. And indeed, our experience with the Dextroscope went way back to 1992 when, when the first demonstrations of the stealth station in Asia, we had a chance to meet Luis and his team in 1992 in Singapore when we actually hauled a stealth station in our luggage to Singapore to show it at the first Asian stereotactic meeting. And at that time, the volume rendering was still somewhat of a dream. Luis showed us his device, and the stereoscopic capabilities were impressive even back then, but to say the fact, at least, they weren't very quick. And now this device has really evolved into a device perfectly capable of the concept of virtual surgery. And what I mean by that is, in this case, for example, here we have a patient with a pituitary adenoma. Here we have the CT scan, which is usually requested by our ENT group. We have the MRI scan co-registered, and we can actually depict the posterior wall of the sphenoid sinus quite nicely. And then using the tools that you'll see in subsequent cases with the Dextroscope, we can actually drill away the posterior wall in this virtual object and demonstrate, in this case, the adenoma and its relationships to the carotid arteries. And so with this ability to do virtual pituitary surgery, we felt that a combination of this device and bringing it into the operating room was important. As indicated, the co-registration techniques really allowed us to maximize our surgical planning process. And we were able to convince the two companies, in this case Medtronic and Volume Interactions, to work together. And in a very short order period of time, the actual agreement was in January, is to take the surgical plans produced by the Dextroscope and port them into the stealth station. At the same time, many of the enhanced visualization tools, such as a 3D volume renderings provided by the Dextroscope, should also be transportable and should also be brought into the stealth station as objects, and that was accomplished as well. Finally, we wanted to be able to do the same sort of three-dimensional visualization that we were doing for surgical planning in the operating room itself. All of us within the image guidance world are used to the typical orthogonal display with 3 two-dimensional images with crosshairs attached. It was our feeling that the stereoscopic capabilities of the Dextroscope would be of value to the surgeon in the operating room as she or he did the operation. And I'm happy to announce that this was literally accomplished a week ago after a very diligent work on all involved. And we were able to perform 2 cases with the combined device, the OR workstation now being called DexView as opposed to Dextroscope, to indicate the difference between the preoperative planning device and the intraoperative visualization device.